and welcome to our webinar today, Welcome to our webinar today, Fevers, Feuds, and Diamonds, Ebola and the Ravages of History. My name is Dr. Joan Reed. I'm Dean for Diversity and Community Partnership at Harvard Medical School and professor here at Harvard Medical School and at the Harvard School of Public Health, and want to begin the program today with a message from our Dean, Dean George Daly.
Hello, I'm George Daly, the Dean of Harvard Medical School. It's my distinct pleasure to welcome you all to this event celebrating the launch of Fevers, Feuds, and Diamonds, Ebola and the Ravages of History, the latest book by my esteemed colleague and dear friend, Paul Farmer. My only regret that I'm not able to join this virtual gathering in real time. Paul, congratulations on your latest book, and thank you for your compassion, your clarity, and your relentless pursuit of equity and justice. Paul's dogged belief that all people have a right to be healthy and his tireless work to make this vision a reality are an inspiration to the world and to me personally. Paul's dedication to the art of reverent listening to the stories of the people we serve and his reverent attention to all the details of a person's life and to the social, historical, and political context within which they live are a source of deep wisdom. That wisdom offers information we can use to improve the way we deliver healthcare and build health systems. It also gives us a fundamental insight into the nature of healing and what it means to be human. As an individual, Paul has made immense contributions to the mission of Harvard Medical School, but he doesn't operate as an individual. Partners in Health, the organization he helped found before he was even a graduate of Harvard Medical School, has been an invaluable partner to all of us. Paul's community reaches across geographical and institutional boundaries, bringing together people from across Harvard's affiliated hospitals, from academic medical centers and ministries of health around the world, and from community health centers and the communities they serve. His work has built an unparalleled platform to provide care and to create and share new knowledge about how best to heal the world. During the West African Ebola crisis that is the focus of Paul's new book, the most immediate goal was to save as many lives as possible. But putting in place the staff, stuff, space, and systems necessary to save lives also made it possible for members of his team to do things like generate new clinical and basic biomedical knowledge about the Ebola virus and the disease it causes, and to field test revolutionary rapid diagnostic tools in the depths of the outbreak. These life-saving emergency efforts also enabled Paul to conduct the kind of deep, qualitative research that has brought us insights that are helping all the communities touched by his work prepare themselves to cope with the many other challenges to health that comes along, including the novel coronavirus pandemic. That includes our own communities here in Massachusetts, where Partners in Health has played a key role in bringing home to the U.S. the lessons of the importance of social support, community engagement, and basic shoe leather epidemiology, which we need to confront the COVID pandemic. So Paul, again, let me offer you my gratitude for all that you do and my deepest congratulations on this exciting new book. Welcome and enjoy the rest of the program.
I want to thank George, Dean Daly, for that and apologize for the black square that you all saw on your screen, but we didn't want to stop the video with what he was saying. I want to turn now and just introduce Paul and then talk a little bit about the book. Paul Farmer, so I'm going to give you part of his bio, but I'm going to say the most important thing about him to me is that he's my friend. So I start there. But he's a medical anthropologist and a physician who has dedicated his life to improving health care for the world's poorest people. He is a professor and chair, university professor and chair in the Department of Global Health and Social Medicine at Harvard Medical School, and co-founder and chief strategist for Partners in Health, an international nonprofit organization that since 1987 has provided direct healthcare services and undertaken research and advocacy activities on behalf of those who are sick and living in poverty. He is professor of medicine and chief of the Division of Global Health Equity at Brigham and Women's Hospital, the winner of many honors and awards, including the Bronislaw Malinowski Award, Margaret Mead Award from the Society for Applied Anthropology, and the Outstanding International Physician Nathan Davis Award from the American Medical Association. We will be hearing from Paul in just a few, but I want to tell you a little bit about the book. Fevers, Feuds, and Diamonds, Ebola and the Ravages of History. This book reflects on the lived experiences from Partners in Health response to the 2014 Ebola outbreak in West Africa, while offering an in-depth historical and anthropological analysis on Ebola and previous epidemics. It closes with a reflection on COVID-19, racial injustice, and lessons learned as of April 2020. But for me, this book ties the past to the present and underscores the importance of knowing and understanding the ways in which disparities and oppression and injustice become part of the norms, so much so that we lose our capacity to even see them in action. But this book brings them forward. It names them, it makes them visible, it makes us have to reckon with our history and understanding what we need, what we are faced with today. When I look at this book and I think of where we are in our country today with coronavirus and COVID-19, I think of Massachusetts and more than 33,000 infected and more than 1,000 deaths. I look at our nation with more than 11 million infected and close to 250,000 deaths. When I look at yesterday, where there were over 150,000 cases and over 1,700 deaths, that's more than one death per minute. When I look at worldwide and 55 million cases and more than 1.3 million deaths, it's a travesty, it's a tragedy, it's wrong, it's an injustice. And how did we get here? What do we do now that we are here? And how do we prepare to have a different kind of future? Because pandemics are not over. So what do we learn and what are the lessons that we take away from this? So I thank you for your contributions, Paul. I thank you for me linking this past to present, because this context is so very, very important. There are three major themes within this book: the embodiment of histories of injustice, from slavery to colonialism to structural adjustment to the modern extractive trades. Another about control over care, clinical response. And another about the 5 S's, the ingredients of social medicine, the staff, stuff, space, systems, and social supports that are brought into play in managing pandemics. We have a wonderful panel today who's going to share with us some of their reflections and their perspectives from the book and as they relate to these 3 themes. And I'm going to introduce the 3 panelists and then turn to them. I'll introduce them all at once. And our first panelist for today is Dr. Pardis Sabeti, who is professor at the Center for Systems Biology in the Department of Organismic and Evolutionary Biology at Harvard University and the Department of Immunology and Infectious Disease at Harvard School of Public Health. She is an institute member of the Broad Institute of Harvard and MIT and a Howard Hughes investigator. Dr. Sabeti is a computational geneticist with expertise developing algorithms to detect genetic signatures of adaptation in humans and the microbial organisms that infect humans. Also a a winner of multiple awards and honors. She was the Time Magazine Person of the Year. She has an NIH Innovator Award, the Smithsonian American Ingenuity Award for Natural Science. She was on the board of trustees of MIT and the National Academy of Sciences Committee on Women in Science, Medicine, and Engineering, and is co-founder of Sherlock Biosciences. Our second person who will be speaking about and providing their perspectives is Dr. Michelle Morse, who is an internal medicine and public health doctor who works to achieve health equity through global solidarity, social medicine, and anti-racism education and activism. She is an internal medicine hospitalist and co-founder of Equal Health and assistant professor at Harvard Medical School. She has served in the past as Deputy Chief Medical Officer at Partners in Health and Assistant Program Director for the Internal Medicine Residency at Brigham and Women's Hospital, and now serves on the Board of Directors of Partners in Health. She is awarded as one of the 40 under 40 leaders in health from the National Minority Quality Forum, and the Society of Hospital Medicine recognized her as an excellent for her excellence in humanitarian services. Our third speaker today is Dr. Salman Khashoggi, who is going to be sharing his perspectives. Dr. Khashoggi is a professor in the Department of Global Health and Social Medicine and the Department of Medicine at Harvard Medical School, and director of Harvard Medical School Center for Global Health Delivery, Dubai. He also serves as a physician in the Division of Global Health Equity at Brigham and Women's Hospital. He's held multiple positions, including chair of the Greenlight Committee Initiative, a Stop TB partnership, with WHO, and co-founder of Advanced Access and Delivery, a nonprofit committed to addressing critical challenges in access to medicines and the delivery of comprehensive healthcare, particularly for economically and socially marginalized groups. His anthropological work focuses on the anthropology of policy and healthcare delivery. And with that, I want to turn to our panelists. And as I said, we begin with Party.
Hi. Well, it is a pleasure to get a chance to speak here. So Joan kind of explained her way of, the many things that Paul is. And to me, my first interaction was Paul as my teacher. And I took an ethics course and a public health ethics course as a medical student with Paul and Jim Kim. And I remember the first day of the class just thinking it was just really funny. Everybody was going around introducing themselves, but they introduced themselves and then they'd be like, and I'll be honest, I was kind of one of these people that's like very clueless until I know something I don't know. So I didn't really even know who my teachers were. I just was interested in the topic. But like the course went around and one by one, everybody stepped up to like introduce themselves and they went off on a long tangent of just, Paul, you're amazing. Paul, you're amazing. Jim, you're amazing. It was just like, I was like, what's going on here? This is like literally just one person after another not being able to stop themselves and be effusive to the human beings that these two people were. And I find myself now just wanting to start by being like, Paul, you're amazing. You're just an amazing human. And so many years later, I'm just still kind of dazzled by you and who you are in this book. And the fact that you wrote this book with everything you have going on, the fact that there's hundreds of pages of an exposition on the history. It's got everything. And it's an unbelievable piece of work that could be done by you and does justice to who you are as a human being. It's funny because, I will get to the book in a second before I do my Paul as amazing, but I'm not doing this just for this, but Paul, you might see here that this is, everyone keeps asking me, what is this picture? What is this that's always in your backdrop, wherever you're talking? But, I had a very terrible accident a few years ago and I was in a very down place. And I just get this gift from Paul that's like, this is for you, drawn by his daughter, who's of course also amazing. And just being like, want you to know you're appreciated and you're well. And I was like, so when I kind of think of the S's, the staff, the stuff, the space, the social systems, and there's also this saint who exists. And I don't like that word saint because none of us are really saints and all of us have flaws. But if there was anybody that was close enough to that, it would be Paul. And I just want to say that this is, this book and everything that it's about and that it stands for is this just beautiful testament to the tour de force of a human that you are. And it's both the sort of clinically sound, historically accurate, but then tells the story of the individuals, and through that lens gives you that sense of what is needed. And so kind of coming to me and why I'm here, in part, it's because I'm grateful to know Paul, but because I was, in that story in some small way, that I was, there's a character and a central individual in this book, Dr. Shikumar Khan, who I was working with in Sierra Leone. I'm a researcher who does Ebola work, and another virus. I was studying another virus called Lassa virus, talked about, and we were. I had come to know Dr. Khan through our work together at the Kenema Government Hospital, where much of this devastation occurred, and we were just in this point, and Paul talks about this. We were just in this point where we were thinking, Dr. Khan was somebody who was very ambitious for his country. He had many opportunities to work outside of Sierra Leone, but he very much wanted to bring a better healthcare system, a better, more just, and scientifically leading edge system in his country. And so we were working together trying to build a surveillance system when this outbreak came and hit. And so that's sort of where what my bit part in this larger story was, just to be his friend, to know from the inside what he was struggling with when this outbreak came, and when he found himself at the center of this tornado. Paul very much describes, a lot of this is sort of thinking about all the different components of this, the injustices we need to think about, but Paul very much describes, what sort of shocking facts about, what happened. And it was not just, so one kind of key tenet of the story is the fact that Dr. Khan was denied ZMapp, and that he, that actually what was sitting by his bedside and he could have received ended up going to Americans who both recovered even. But having been on the inside, having been on a bunch of strenuous calls that were leading up to those decisions, it was sort of shocking to us that he was denied this, considering that he was a human. Probably one of the reasons when we think about experimental drugs is, who is the person that can make those decisions carefully, and there's no person on the planet that could have done that more than Dr. Khan. They aren't so that was like one very shocking fact, that he didn't have that opportunity. And I know it was a difficult time, and there's all of these complexities that we talk about, but the other kind of component of that is he was even denied even more routine care. And it's and I think that a lot of the themes through this book is talking about that, about the deeper injustices, the deeper dysfunctions that run across the board here. And we see it, as Joan said, we're seeing it again and again. It's amazing this book is coming out in a time when the whole world is understanding what it's like to be in an outbreak from every standpoint. And we see all of the deep divides that exist between us and humans. And so this story, I think I was asked to speak to a little bit of the clinical aspects, and I'm happy to talk more about it, but it's really fundamentally that story of the constellation of the many things. I often say that viruses expose and exploit the cracks in the trust in our society. And they do, they take advantage of that. And I think that by Paul going deep into the history of this region, you start to really understand how this can happen. These pandemics are caused by viruses, but they are caused by human failures, and human failures of taking care of each other. And I think that if anybody wants to learn about this is an exposition. It takes you deep into every aspect of that story. And so, Paul, bravo for this and for everything that you do. It's just another manifestation of the incredible human that you are, that while you are driving important scientific questions, medical questions, and bringing cutting edge, health forward, you're actually just looking around and you're saying, wait, what's going on there? And what's happening there? And tell me more about that background. And I think that's where you should appreciate that your genius comes from the fact that you're like, Pardis isn't well, and I'm just going to think about her. And I'm going to take a moment for her. And so I don't know how you do it, but it's that makes the genius that you are, is that you're always looking, you're always watching, and you're always thinking of others and how we came to be. So thank you.
I'm just going to ask before we move on, can you just tell a little bit about Ebola, just so that not everybody might understand?
Yes. Oh, yes. So yeah. So, and the book actually does a very good job of describing Ebola too. Ebola is, many people came to really know Ebola because of this outbreak that happened in 2000. Started in 2013. We heard about it in 2014, and then spread across. It began in this small village in Guinea, likely believed to have started with a young boy who may have been infected by, playing in a tree were inhabited by bats. It's not clear, but that's the likely index case. But it was a virus that sort of spread from there, somewhere in that village, possibly, and into the region. And by March of 2014, had driven into a major outbreak, and then quickly moved into by that April it was in Liberia. By May it was in Sierra Leone, and we confirmed that first case at kind of a government hospital, and it exploded. The virus itself, is we have heard about it. Terrific books like The Hot Zone by Richard Preston were the first to bring it to our collective conscious and put sort of outbreaks on the map and as a thought process. But Paul tells it as a much more complex story. It's not something that every person who gets it bleeds out of their eyes. In fact, as he says, most people survive. Most Americans who got treatment do survive. And so it is a disease, and it's a very devastating disease that one might be concerned about, but it has many faces. And many people may be getting it, and just like in COVID, they may be asymptomatic. And some individuals get it and become a little ill, and others die. And a lot of this also tells us that the medical care makes a difference. And ZMapp, sorry, I mentioned it, I should have started with that, but ZMapp was an antibody treatment that was experimental at the time, but came to the forefront because of its success in early cases. And so, and so it's a much more lethal virus than COVID, but not quite as easily spread. And so we could contain it. The worry everyone always would have is something as lethal as Ebola and as widespread as COVID. Something to pay attention to. But many of the lessons learned and the storyline is similar. I got lost in just being like, Paul. It's just going to tell you more about how awesome Paul is. It's amazing.
You can go ahead and say more about that, Pardis.
Turn to Michelle now.
Great. Yeah, thank you. Thank you, Dr. Sabetti, for that just beautiful human summary and reflection, and for your courage and for your work as well. I really appreciate it. I'm glad that you started. I'm honored also to just be a part of the conversation today and reflect on the book, for sure, which I am still powering my way through, all 600 pages. I haven't finished it. But I'll just say it's obviously a profoundly difficult and painful story, but also a story that we need to all be, flexing our emotional and psychological muscles to read, because it's beyond relevant for what's happening in the world today. And I will also say, Paul, as heavy as it is, it reads much easier than the uses of Haiti. So thank you for that. That's progress. I want to start just by reflecting on just how human of a story it is. And, I had the honor of getting to spend just a little bit of time in West Africa during the Ebola epidemic. And my time was in Liberia, not Sierra Leone or Guinea. And I wasn't doing clinical care. Sorry, my cat's coming in. I wasn't doing clinical care. I was involved in just kind of understanding the work that the team was doing to try to build in, I would say, both clinical education and political education as the projects and work in Liberia, specifically in Harper, in the south, kind of the far southern part of the country, as that work was happening, was being led by my dear friends and mentors who are Haitian physicians who taught me everything I know about how to how to provide care in rural Haiti, and they were doing the same thing in rural Liberia. We've lost some of them since, but those were the people who really shaped my consciousness and shaped so much of how I myself try to merge political education and clinical care. And the time that I spent there really brought me immediately to the questions of how history shapes everything. And you can't avoid that in Liberia, specifically in Harper, where you walk down the street from the Partners in Health office in Harper, and you see a 120-year-old kind of mausoleum to Masons, and you immediately, of course, learn about the colonial history and the connection, of course, between enslaved people in the U.S. who came to Liberia, and the long and complicated story that unfolds from there. So you can't not touch, feel, experience that history in Liberia, and I suspect it's similar in Sierra Leone and Guinea, though I haven't visited. The reason why that makes it human is because I think it's, in many respects, it's very easy for us to want to erase that history, forget about it, marginalize it, or just not center it, especially when we're talking about healthcare. And what smacked me in the face, of course, as soon as I hit Harper was, you can't do that here. I mean, literally every space that you're in, it feels, I don't know how to describe it, but history is ever present in every single space. And the other reason I say that this is such a human story is because I, of course, immediately connected with the story of Dr. Humar Khan that Dr. Sebedi was just mentioning. And Dr. Khan's story, I never had the honor of knowing Dr. Khan myself, but you can't not read the story as a health worker and immediately and constantly, and this is what's been at the forefront of my mind for many, many days now that I've been reading the book. You can't not ask yourself, what would I do in that situation? What would I do if I was Dr. Khan in rural Sierra Leone, knowing exactly what was happening and exactly what was coming, knowing the history of international lack of response, international willful lack of appropriate and full and material response to epidemic after pandemic after epidemic after pandemic, knowing all the history of failures of global responses for prior pandemics, knowing exactly what was needed to respond effectively, and then not being able to get that there when it was needed most. And then continuing day after day, hour after hour to work in that place and in that space, knowing exactly what it could mean for your life, for your safety, for your family's safety. The choices that Dr. Khan made are again, choices I'm constantly reflecting on as a doctor myself, and wondering, would I have done the same thing? Would I have left? What would I have done when I started having symptoms? Where would I have gone? Who would I have called? And I just can't describe enough how important it was for me to have to reckon with that, and to read it. And then, of course, to think about, well, what does this mean for me going forward and the choices that I make as a physician going forward, particularly as someone who is extremely privileged as an American physician in the global north with an appointment at one of the wealthiest universities in the world. So I'm obviously still processing that. And I think that I have a feeling that there are going to be many, many, many more parts of the book that are going to take me a long time to process. But I just want to honor Dr. Khan and his memory and his sacrifices, because that was the part, the humanness that struck me first when I was reading the book. I also want to just reflect for a second on how far have we come? I mean, that was the question that also slapped me in the face reading this book was, from 2014 until now in 2020, in the midst of a once-in-a-century pandemic of COVID-19. How far have we come from 2014 till now? Would we do it differently if it happened again today? If what happened during the Ebola epidemic in West Africa happened again today, would we do it differently? What would we specifically do differently, and how would we do it differently if we were to do it differently? And I just had to write down a couple quick thoughts because it made me think a ton about how, the challenge of doing political education at scale. And that's political education of health workers, but of civil society, citizens, community members, the average kind of person in the world. Kind of, would Americans have the same response to an Ebola threat today as we would have in 2014? And if yes, kind of what level of political education is needed to have a response that's about, to Dr. Farmer's point, care and not control? And is it even possible to get to that point? It did, of course, make me also thankful for the social movements that are happening right now all across the world, because to me, those are the most hopeful way of doing and ensuring political education at scale. So another shout out and prayers up to Black Lives Matter for all the work that they're doing to advance anti-racism and to advance political education at scale. But I'm not sure that we would have the same response. And if you look at what's happening with COVID, the answer, unfortunately, definitively is no, we've chosen control and not care again, at least at the federal level, at the global level. That doesn't have to continue to be the case. But I worry, as I'm sure all of you do, that we're making some of the same mistakes as a global community. And certainly we have an opportunity with having a new president who's not fascist to change course. But I worry tremendously about how far we've come and how far we haven't come. I just want to also mention that I think the approaches to vaccine distribution are one of the ways that we're going to be tested to that very question about how far have we come. And I think, other things tell us that, again, we have a very long way to go in the health worker community, specifically in the physician community, for us to not repeat those same patterns and make the same mistakes. And I'm thinking specifically of some of the colorblind advocacy work and colorblind policies that are coming out, and how physicians have run to support those. I worry about that. I also worry about, just academics who've come out, for example, in support of not ending race modifier in EGFR. Examples abound, right? And some people might be wondering, well, how does that connect to our response to Ebola? It's a question of political education, consciousness raising, and understanding history and what it means to be, what structural racism actually means and looks like, and what neocolonialism actually means and what it looks like, and how we as physicians in particular, who have disproportionate power in our health and healthcare system, what responsibility we have to not be complicit with those systems, and how easy it is for us to fall into the pattern of keeping things the same, like correcting kidney function for race. Those kinds of things need to stop. And again, if we can't continue to do political education at scale, I worry that the next COVID and the next Ebola is going to produce the same results. I also just want to say that I really want to mention just how important it is for health workers to understand the importance of our leadership role as well, in taking courageous risks and in taking important risks when it comes to not just care delivery, but all our political and advocacy related stances. And I think that we have some signs of that. I mean, I certainly was someone who never thought that the American Medical Association would pass a resolution recognizing structural racism. And at the same time, we still have so much further to go. And I think Dr. Khan's example, again, offers us this path and this model for sacrifice. And then I think the last thing I want to just say is how important I think it is for us to build an alternative nexus of power, as me and my colleagues have written about recently, when we used critical race theory and interest convergence specifically from Derek Bell, and tried to apply it to what's happening in the policy landscape right now in our country around the response to COVID, and what that means for the Ebola response, as described by Paul in the book. Interest convergence as a way of understanding the changes of the past and seeing change as something that happens more readily when interests of elites, unfortunately, are aligned. That's why the prescription of building an alternative nexus of power is so important, because we can't wait another generation for interest convergence to happen. We can't, of course, sit back and watch, hoping that the interests of us who believe healthcare should be a human right, or for us who believe that we have to end the colonial influence of colonial powers on how we deliver healthcare. For all of those of us who see all of those social and structural forces in history at work in every single moment of every day around the world, and especially in this country, we can't sit back and wait. And so what does it look like to build this alternative nexus of power, I think, is one of the answers I'm going to be looking for as I continue to read the book. I suspect that there are going to be some signals and signs in there. And I certainly believe that one of the answers for how we build that alternative nexus of power is speaking with a unified voice about our policy interests and our advocacy interests. And I hope that those don't continue to be self-interested policy interests that I see the physician community lobbying for on Capitol Hill in my current role as a Robert Wood Johnson Health Policy Fellow. I have a lot more to say, but I'm going to stop there and say how appreciative I am to have this book in this particular moment in time, in particular, and again, how thankful I am for the sacrifices that Dr. Khan make, and how hopeful I am that we don't need to have more Dr. Khans in the future for the world to wake up to what we need to do in terms of the effectiveness of our response and in terms of choosing care instead of control.
Thank you, Michelle. Solomon?
Thank you, Joan, and thank you, Pardis and Michelle, for such fantastic comments. So I've been asked to talk about how this book relates to social medicine. But let me start by saying, first of all, that this is a beautiful book. It's long, as Michelle has alluded to. It's a beautiful book. It's beautifully written, and I want to thank Paul for writing it and sharing it with all of us. And to be fair, I'd read parts of it before when Paul was writing chapters when he visited the Harvard Center for Global Health Delivery's hub in Dubai on the way back from West Africa. And that was a time when his memories were very raw. and recounting the stories at that time, there were lots of tears. And I've also had the privilege of reading parts on airplanes and other places when we were together, and I've heard the stories as he reported back from West Africa during the epidemic. And in fact, he shared parts of his experiences with students and faculty in the course that we teach together with Arthur Kleinman and Ann Becker. So he brought all of this to the students in real time with what we came to call dispatches from West Africa. So reading the book allowed me to experience somewhat familiar terrain as an observer of what Paul has been living and processing for the last few years, which, part of which I've been, privileged to share. And yet, as a reader, I couldn't help but being drawn into the stories, as Michelle and Pardis both point out. It's beautiful writing, and I was drawn into the woeful descriptions of extraction, suffering, violence, exclusion, all of these contributors to the health deserts that Paul described, and about which I'm going to expand a little bit more. In fact, as I was reading it, there were times I found myself in suspense, and there were often times I found myself in despair that we've learned so little from this disease, from disease to disease, and from time to time. For those of you who are going to read the book, you should know it's written in waves. So as the reader's understanding of the different layers develop, the book returns to the core stories, and we've heard some of those core stories. And you're left with the sense that you're peeling an onion. With each layer, you sense more, you know more, you feel more. And I have to tell you, at times, you're truly left tearful, very, very much like onion peeling. And so, because it was a product of so much thought and of being present during the epidemic, for me, this book encapsulates the social medicine approach to disease, illness, and caregiving. It encapsulates how medical phenomena can only be understood in context. So, to put it in biological terms, Fevers, Feuds, and Diamonds forces us to really view disease in West Africa in terms of the host-pathogen interaction writ large. So what Paul has given us is a brilliant biosocial analysis of disease, something many of us can understand better today as we live through the COVID-19 pandemic. And as Michelle has mentioned, we're forced to parse out what aspects of its spread are linked to the pathogen as a biosocial entity. So social in the sense of its linkage to deprivation and poverty and race, and what aspects are linked to the host, so biologically, and as a product of a vicious social and political landscape. So this isn't Paul's first work where he's done this, but in Fevers, Feuds, and Diamonds, he has gone into an incredible amount of historical depth. So he's given us a social history that's truly searing. He's gone deep into political economy, an understanding of how the colonial goal of extraction and post-colonial extraction destroyed the opportunity to give care, to be human, and to be humane. And by highlighting this, he shows us how and why when Ebola arrived, and of course, he points out, and we know that it's one of the many diseases to ravage the region, that when Ebola arrived, the staff, the stuff, the space, the systems were not there, and much needed care couldn't be provided. So, and instead of looking at health issues as being rooted in the present, I think as we're wont to do, Paul leads us through a painful history of what he calls punishment and profiteering, a cycle of disease, repression, and colonial extraction. He gives us this history, like you look at it and you say, this is a history of double standards, a place where allegedly bedrock ideas such as liberalism or liberté, égalité, and fraternité were set aside, as well as the most basic ideas of medicine, such as treating shock with fluid resuscitation. So this isn't unique, of course. We've seen this throughout the colonial period and afterwards, but Ebola underscores the violence that it causes. And for me, and perhaps I'm biased being with a colleague of Paul's in the social medicine department, but this book is pure social medicine. It ties together political economy with social history and pathophysiology in a way that reminds us that the practice of medicine, so the science of medicine, divorced from an understanding of the social world, will fail to achieve its purported goals. Translation of medicine from the laboratory to the clinic is just one step, the first step. Without translation into caregiving and communities, we can't achieve our goal. So as you read this book, as you go through these waves, as the onion is peeled back for you by Paul, you're left with some key social medicine pearls. And these pearls are perfect for our students, and Paul teaches this to them constantly, but it's also, I think, for all physicians, scientists, thinkers, policymakers, humans. These are important things to know. So I've kind of tried to distill a few of these pearls. The first is a renewed understanding of a renewed and I think more correct understanding of pathophysiology. So this is critical as we think about health, therapeutics, and health delivery, right? So a number of times in the book, Paul quotes Pasteur saying that terrain is everything. Host factors are everything. And as we approach the 150th anniversary of social medicine at Harvard next year, Paul forces us to confront the question of whether the Ebola deaths in West Africa were caused more by the virulence of social conditions than the virulence of the pathogen. This is just, I think, the profound framing of this book. Was it caused more by the virulence of social conditions than the virulence of the pathogen? And this is at the heart of social medicine. Paul puts it beautifully. He says, quote, social medicine includes the study of how pathogens and pathogenic forces get into the body, how they take their toll, and how and why these processes vary so radically from time to time, place to place, and person to person. And, as somebody very steeped in medicine, for me, I looked at it and Paul takes the idea of host factors, something that many medical schools today are wont to study only at the molecular level using genetic tools, and shows us that the entry of the Ebola virus into the human host is not simply a molecular event. It is indeed, but it's not simply that. Inequality plays a significant role. And in fact, Paul lays out in detail that to just focus on the molecular or the cellular is to forget a critical component of the terrain, if we use Pasteur's word. So that's one of the key pearls, I think, is that we really have to think about this renewed understanding of pathophysiology and where the boundaries of it. It goes from the molecular to the social. People, our cells and pathogens don't exist in a vacuum. So the second pearl, and very close to this, is the corrosiveness of what he calls the control over care paradigm. At the end of the colonial period, little could be found, he says, with respect to health infrastructure. So, you read this tale of woe, really, and you hear that there are few doctors, few nurses, few other trained people, and very little as far as health delivery systems. And the reason, of course, is this long history of containing people whenever disease is ravaging the community or there's an outbreak, and giving them very little medical care. So Paul lays out the story that while European colonialism extracted much in the form of diamonds and other goods, it didn't bring healthcare. Instead, it implemented policies in these places that were not implemented in Europe. And when one of the world's biggest public health interventions was launched to stop the spread of Ebola, the focus again was on containment. Those suffering from illness were not treated with life-saving treatments. And in this case, it was the provision of intravenous fluids, electrolytes, supportive care, really basic things that we teach our interns to do at hospitals. And the basics of what is regularly done, next door at the Brigham or at Mass General, the charting of fluids going into a person and out of a person were not done. And the reason for this was always something like, well, it's not in the protocol that was determined by the headquarters of various international organizations who were serving in West Africa. And so Paul breaks this down and he says, of course, this was driven by early logistics, but it was driven by bureaucracy. It was driven by managerialism. It was driven by double standards. But he also argues it was driven by this colonial fear of contagion, fear of the other, the colonial other. And it was this fear of contagion that led international experts to argue that giving oral rehydration salts to people who were severely dehydrated with continued vomiting and diarrhea was better than receiving IV fluids. So this was not sound medicine. And Paul weaves this tale that shows that this type of approach, combined with defeatism and low aspirations on behalf of others, and in this case, on behalf of the colonial other, was deadly. And medical practice, as a result, was shaped into what should have been an unrecognizable form, but sadly is very recognizable for people who have worked in a variety of interventions. So, of course, the result was that people who could have been saved with giving, basically salt water in their veins died. And caregivers watched them die. As Michelle has talked about, we have to ask what were they thinking, what were they feeling? And within this frame, Paul shows us how the ideas of prevention and care were pitted against each other rather than being complementary. So basically, in the end, he says, failure to treat rather than treatment failure was central to Ebola's pathogenicity. That's just critical. And he actually says that the view that the pathogen itself determines everything, that the host and his or her social conditions are irrelevant, legitimates therapeutic nihilism and actually perpetuates all this. And we have to change that. And I think Michelle has just touched on that we have to change this in many ways, not just when it comes to Ebola. So, I think as you read this book, it points out he points out that the pathogen that killed people in West Africa didn't kill most Americans and Europeans. And it's this complex web that underpins that. Let me just quickly jump to two other points. One is race and health. And we heard the story of Dr. Humar Khan, which Paul comes back to many times. And he didn't get the medicines that were sitting 100 feet from him because of this false idea of equity, that, oh, we don't want to give him something that other people here can't get. And yet when two individuals of European descent, two American missionaries became ill, the drug was flown from its place almost at Dr. Khan's bedside to where they were so they could receive the medicine. So, and of course, the people themselves were flown out of Africa so they could receive the right type of supportive care. So Paul doesn't say that ZMapp or any of the drugs were a panacea, but he attributes it to care access to care and the very act of caregiving that actually mattered. And that's what was lacking. So this story of Humar Khan, and if anything that you read in the book, just read that. It is the coda to the history of slavery, racism, colonialism, and war that Paul tells us about. And the idea that Dr. Khan should not receive something that others like him weren't getting is the key idea. And in that calculus, and this is a calculus we see over and over, even today in America, in that calculus, we see the logical conclusion of 500 years of othering that's born of colonialism, extraction, racialization of extraction, racism, and the entitlement of power. And then the last thing that I think Paul really brings up is this whole idea of health deserts. We have this here. This was clear in West Africa. Colonial subjects paid for colonialism. He goes through this history how money was extracted. They actually paid for everything that they got from the colonizers. And then they had to take on debt. And people knew that the health system was bad as early as 1942, if not before. The US Army noted that public health programs were needed in the region. He points out that in a country where diamonds were being extracted, so flights full of diamonds were flying to Europe throughout the epidemic, people had to endure poverty and a lack of health care that was socially created. And so this health desert is what emerges. And the vulnerability that comes from them is not an accident. It's a social construction born from a deep history and a corrosive political economy. So Paul's writing has changed the thinking of a generation of activists, a generation of practitioners, a generation of scholars. And, as we stand here on the eve of Harvard pushing the idea of social medicine for the last 150 years, that social medicine is a critical part of the science and art of medicine. I want to end what I'm saying with a quote from Paul, who puts it best in this, truly monumental work. He says, "If nothing else, Ebola teaches us the importance of social medicine, which focuses attention not only on why plagues afflict some and spare others, but also on how inevitable mutations, social and biological, among pathogen and host, are related to different risks of infection and death." I just want to end by saying Paul's work teaches us all how to repair the world. This book is part of the mechanisms we need for remediating centuries of injustice. Thank you.
Thank you, Salman. Thank you to all three panelists. Paul, I want to turn to you in responding to our three panelists.
Well, it's hard, Joan, to respond to those comments. I mean, I feel a certain, I'll just say it, affection and gratitude to three people I've known so long. And, if Salman doesn't mind, and I don't think he will, that I've had the good chance to teach, and learn from all three of them and work with them. And so, part of the intense reaction I'm having is because it matters so much to me what you, Joan, and my three friends think about this project. Of course, it is just part of a project. The real project is the one that Michelle and Pardis and Salman and you have laid out, the project before us now. And part of the fears that I had in writing the book this way was that it would seem only a tale of woe, as Salman said, that it would seem only, a recounting of the harms of extractive colonialism and racism, which are the two primary noxious forces discussed beyond epidemic disease and with epidemic disease. Because of course, being there in those years, I'm still lucky enough to be working in Liberia and Sierra Leone with so many colleagues who I didn't know only 6 years ago. I didn't know really any of them. I really only knew 4 Sierra Leoneans when I first went there in June of 2014. Of course, Pardis has been working with them for a long time, but that was my first time. And one of them was Humar Khan, and a second one was the surgeon Martin Salia, who I worked with us on a project around surgical care in resource-poor settings, to use the jargon of the day. And both of them perished. And the other two were the director of Connaught Hospital, which is a colonial relic, that looks like it was built in the early 20th century and never cared for. And the fourth was a student of ours from Harvard Medical School, Byler Berry, and many of you know him too, Joan. So I didn't go there intending to stay or work or ever return, in fact. You say such things when you're in a place like that, but that was not my intention. I went from Rwanda to Sierra Leone, and I will say, and Pardis knows this already, that Umar Khan's death on the 29th of July is what really clinched it for me, that this was an assault, an all-out assault, not a microbial assault only, but an assault on dignity. And of course, learning the details from Pardis and others only made me more convinced that was the case. So my real gratitude, my real worry is that I would bring up only the tale of woe and not the joys that we experience and still experience, not the joys of seeing someone survive Ebola, even as you've heard, about their own losses, not the joys of seeing people come together to rebuild. And I mean, the wars there were over only a few years when this hit. And so yes, you're in a clinical desert. Yes, you're in the middle of a terrifying epidemic when things aren't clear at all. But there were so many joys. There was so much satisfaction, and there still is. And I just hope that some of that comes through in the book. And the only other thing I'll say, and then I hope we can turn it back to, let's turn it back to more praise for me. I'd like more of that. Pardis, you could just pick up right where you left off. Is that I have obviously an enormous debt, and to those who were willing to speak with me. And I'm not confused about the fact that I am projecting other people's voices very often. I'm not confused about that. I know the limitations of any kind of ventriloquism, especially across lines of race, class, professional privilege, and gender. And so, I will never stop being grateful to those people like Umar Khan, who was a hero to many of us and many in Sierra Leone, to the others who were lost, but also to those who we didn't lose. And, and finally, the four of you were very much present in my life during those difficult years. I mean, what would I have done without my colleagues, who were willing to cover for me clinically or teaching or administratively, and that gratitude goes to my colleagues at Harvard Medical School. And then finally, I do want to say that there's no there without some reparative service, and that will be the case now with COVID-19. Without actually investing, and sometimes it's staff, sometimes stuff-based systems, always support. Without that reparative work, reparations, then we're stuck. And it just so happens that I'm lucky enough to work with people who, at Partners in Health, certainly, including Partners in Health Liberia and Partners in Health Sierra Leone, work with people who believe that we do need material reparations, that we do need to acknowledge that some places are clinical deserts and some places, very few, alas, are clinical oases by comparison. That begs the question, and I think this is better, Joan, for any discussion, but it begs the question of, well, if we have so much clinical nihilism in the post-colony, which has been everywhere that I've gone. It's always, it's not cost effective, not sustainable, not feasible, not prudent, and it's always for them, and that them happens to be Black and brown people. But here we're seeing a very frightening containment nihilism in the United States. You know, when you have an outbreak in the Rose Garden of the White House, and you see in the newspaper the next day that we're not going to do contact tracing as an announced, or that we can't control the epidemic in the United States. I mean, you're running into other forms of nihilism. And you know, I'm just like all of you, I'm still struggling with that as well. So I hope that the book isn't a downer. I know it's long, Michelle, but I hope there's some joy in it. And if there's not, then I need to just underline how much joy there has been in the work, including the work in Sierra Leone, including the work in Liberia, and getting to know this new part of the family has been very, I'm just going to say it again, very joyful for me and for many others. So thank you, all four of you. This is just such an honor. And indeed, you know, this is my idea of a real book party. I'm sorry that we're not all together in the same place, but you know, this is just so meaningful to me at the end of this particular part of the project.
So Paul, thank you for that. But part of what I want to say is that this is not in any way a downer to me. That so much of what we often read or hear in media is the extreme, not this balanced understanding, from Ebola being seen as being just an extreme and not seeing that there were ranges in terms of how it was the presentations or the outcomes from it, to these extremes, to these places where we, as you talk about the nihilism, the not even acknowledging what's going on. And what you did was just bring, for me, part of that truth and that reality. And what you also did for me was bring forward the capacity of the human spirit to survive what Solomon talks about, 500 years of othering, to survive and thrive and come back again in the face of resistance, in the face of denial, in the face of blatant racism and other kinds of things. And to me, that is uplifting. And that's a sign of our humanity, of our spirit, of what's possible. And I thank you for that. I thank you for that. I'm going to ask a kind of different question, because all of us are involved in education. And as you think about bringing forward these historical connections in our medical education, our engagement with community, be it community in Sierra Leone, be it community in Roxbury, right next door in Mission Hill, wherever community might be, these issues of justice and injustice, these issues of humanity and inhumanity and what we're capable of. And how do we bring these lessons into our medical education? Does it belong there? And I'm not talking just about our students. I think about our students. I think about our trainees, our residents, our fellows. I think about our faculty who teach our students. Could you speak to that, Paul, or panelists?
Well, I'm going to hope that Pardis will speak to it as well, since she was good enough. And by the way, the course that she took was an elective. It was called Culture, Poverty, and Infectious Disease. But my friends all called it Poverty and okay Culture and Infectious Disease, because we were militant about, again, the material basis of privation, anyway, I've been lucky enough, to be an infectious disease clinician, but always, and it's really why I came to Harvard Medical School. I mean, I came to Harvard Medical School because I was lucky enough to get into it. And I'm still stunned by that, by the way, all these years later. I started in 1984. I'm still going, really? Did I? I mean, how could that happen? But once here, literally in the first week here, I was able to pursue an interest in social medicine, and and then degrees, and so I've been raised up by people as a clinician. And Michelle said it too, when you work in Haiti for a long time, you don't have the option of not learning these things. And maybe that's the debt that I should have underlined even in talking about West Africa, is that, when your first teachers are, the Haitian people, then, you're in good stead to understand social medicine. And indeed, I was lucky enough to have a year there before starting medical school. But always, I've been raised up by faculty and friends and patients who think it's important to understand health disparities, social disparities, one's chances. And, my colleagues like David Jones, who push forward, our colleagues like David Jones, who push forward the agenda in teaching social medicine, are also unswerving in their conviction that this needs to be part of everyone's of clinical training. I mean, just an example that I gave yesterday in an interview around this book was, why is there vaccine hesitancy? Whether you talk about the Ebola vaccine or a COVID vaccine, among whom is it strongest and why? And can you find reasons that it would be so? It was easy to find them in West Africa. And of course, it's easy to find them in the United States, just because of spending more time there. So I think that we skip over social medicine at our peril. And that doesn't matter if you're a computational geneticist or a tuberculosis specialist or a medical education specialist who's an internist or a pediatrician who's a dean. In every instance, we need social medicine to keep us oriented to person, place, and time, especially when we're facing crises like this one. Pardis, you got to say something. You're the real scientist.
Well, the funny thing was that I was just emailing Katie because I was like, the Joan, this is another embarrassing. I'm an embarrassing fact on this, but I was listening to your entire question, but I missed part of it because I just finally noticed my chat box, and I had a very sweet message from Paul, and I've become a fangirl because I was literally screen grabbing the message because I'm like, I'm going to keep that one while you're asking. And so I got the general frame of it, but is the question really about like,
it's really about, so the reason I invoked you is because, how much of medical education should include social medicon. And,
yeah, okay. Yeah, okay. Well, I mean, that's an interesting question. So I think okay, that was the question. I think it's like, I got everything around it, but I was like, I'm sorry, what? I just trying to save that. That's going to be for the record. I've turned into a complete fangirl. This has happened. This is a transformation that has happened.
Mutual.
But I think that I like I said, at the time when I took that class, I didn't actually know anything about partners in health. I just looked at the topic and I was like, this is interesting. And and I am grateful that Harvard Medical School as a in its education system allows for a lot of that opportunities. There's a lot of patient teacher, there's a lot of like patient interaction education that is in play. And that course was really mind-blowing, Paul. I really do think it was, like I said, after we got through the days of accolades, we really got into it. And the framing that you have is critical. And I think, like you said, it's surprising, but that it's so not inherent. Like you would think that it would be natural, that you wouldn't have, like, I remember when we had our this course that we had, it was sort of, I think it was something like patient doctor, I think was what the course was. And I remember at first being like, why are we doing this? We're literally doing a course to talk about how to talk to people. And it was kind of a joke amongst our class. So now we're going to go talk about our feelings. But then we actually went into the hospital and we saw the way some doctors were interacting with their patients. And we're like, oh, okay, people don't know how to interact with people. Like it's actually, it is interesting. And over time, I think as doctors get busy and calloused and they kind of forget about the humanity that is it. And so this idea of control over care is so critical because I in so many ways, bringing food to an individual, thinking about what they need, where they have to go, is so much more important. It's not just an addition. It is the thing. It is a thing we need to do. And I think that as a student, now embarrassingly long number of years ago, 20 years ago, essentially of Paul's, it was one of those things where no one, while it's something that should be talked about that you think you don't need to bring into it, people weren't talking about it. And I think Paul probably at that point, it's like people are probably like, and this other culture thing. Well, it's like, no, the culture is the thing. It's so much the most important thing. And so you were way ahead of your time. And the fact I actually remember very clearly the story you talked about when you talked about coming to PhD, because actually, am I remembering it right? Because you came in as a doctor and then you decided to enroll in the PhD and you decided to do this very unusual, because I remember thinking, what an unusual PhD to do. You decided to do a PhD, but not in science. You actually chose to do it in this other thing. And I remember that was sort of surprised me. And I was like, that's something I could think about. And to think that you brought this entire other lens and that put you in this very unique position to see things that other people weren't seeing, because they were thinking of medicine as something else. And it's much more holistic than most people consider. It's certainly not about giving drugs and pills. It's certainly much more than that. It's thinking about the whole person and how to make them thrive. And we are seeing more and more now how much health is related to equity and justice and mental health and well-being and all of that, and that you have to bring the whole frame and you have to empower every actor in the system. And I'm grateful for the remarkable things that you did to really show what is possible when we think about the whole human being and when we give agency to the people that we are trying to take care of and see them as a force in their own lives and not some sort of a subject that we are, the kind of idea that a patient is one who suffers and you don't see them that way. I can tell you've never seen them that way. They're a friend, they're a colleague, they're a mother, they're a brother. And you didn't see me that way. I felt seen by you when I was in a dark moment. And I imagine you do that with every individual you touch.
Thank you for that. I have a different kind of question, and it's going to come back to you too, Michelle, because particularly in these times and in the halls of many of our academic institutions, we've become awakened to issues around racism and anti-racism. And in thinking about this, asking about how does understanding our history, how we have contributed, those of us in medicine and science contributed to the conditions that we see today. How should that be informing what we teach and also our responses?
Is that for me, Joan?
It's for Michelle, and then for you also, Paul.
Sorry.
Michelle.
I appreciate the question. I really appreciate the focus on kind of the consciousness raising aspects and how much of a responsibility we have to do that and do it effectively. I think social medicine in many ways offers us a prescription both for consciousness raising as well as for action. And I think understanding structural racism and how it connects to colonialism and all the larger forces related to that. Sometimes we get nervous that that's not medicine or that's not the essence of our field. And you'll see lots of op-eds from some of our colleagues saying we shouldn't be teaching social justice in medicine, or we shouldn't be teaching social medicine. I think there's a deeper battle there that we have to recognize and call out when we see it. And I think that social medicine does help us to do that. I would also say that students this is what students want to be learning. They get it. And I think whether it's structural racism, whether it's neoliberalism, I mean, I'll just say, at least for our social medicine course in Haiti, the most popular course every year is the one on structural adjustment and neoliberalism that's based on Salman's book, Blind Spots. So like it always gets the highest ratings, right? Because when you're practicing in a space and in a place where you see the impact of those policies on patients' bodies, their access to care, their real life human conditions, because you're doing home visits and you're not only, in your exam room. Of course, the natural interest is in really understanding how those larger forces do impact and determine outcomes. And I think structural racism in particular, again, I don't think we thank the movement for Black Lives enough for creating a window where conversations about structural racism are literally happening in every space. And that was just not the case for many, many years. I mean, you, Dr. Reed, Kamara Jones, many others, Paul, Salma, I mean, the people who were talking about how racism shapes opportunity, material conditions, and health outcomes used to be, marginalized and siloed, right? And now everybody wants to talk about it. So, but then again, how do we turn that into a policy prescription again, I think is critically important. And again, I think social medicine helps us create that policy prescription as well.
So Michelle, I'm going to thank you for that. I'm going to thank you for policy prescription, but I'm also into an action prescription. And so where is action in all of this? And you've alluded to Salman's book. And so I'm going to ask you, Salman, to speak on this issue too, before we turn back to Paul.
Thanks, Joan. I want to say that we've seen students imbibe in social medicine. I think Michelle is right. They really like it. This is what students like. And the question I always have is, how do we teach students to stand up? In the book, Paul has this scene of when he is walking through the clinic for the first time, and they're watching two patients virtually fall dead. And the young doctor that's there, says, Paul says, do you have any electrolytes? Do you have any data? What's going on? And the doctor says, and they're taking a blood sample to check for Ebola. And Paul says, do you have that? And he said, no, we don't draw for that. And Paul said, but you're drawing one sample. Why don't you test for that? And he says, oh, it's just the protocol. It's not in the protocol. And the protocol is, of course, sent from other people. And we've heard this repeatedly in the Black Lives Matters moment. We've seen people say, oh, police were acting according to protocol. And what we should all be saying is, the protocol is wrong. The protocol needs to change, right? And we do that with neoliberalism. I hope we do. We say, no, this is not the formulation of the way you organize a society where everything is based on money. Things are based on facts like you're human, or that you have dignity and other things. And so I wonder, like, as we're teaching social medicine, we have to somehow teach our students to stand up and say, this protocol is just wrong. I'm sorry, we can't accept this. That is not the way you give care to people who are dying. That's the challenge we face as a medical school, and many medical schools face around the country.
I think as you talk about that, I'm reminded again of those questions of what would I do then? What would I do today? And what will I do tomorrow? And then what does the system do? And how do we move a system?
And Joan, I'm not saying it's easy, because I think there's so much courage required, and it's hard. I don't blame the person that said it's the protocol, because it's a junior doctor who's being told this is the way we do it. But it's hard to push back and say no. We're seeing that with the Black Lives Matters movement, that people are saying, no, this is not the way we should be doing it. But it's hard to bring it into medicine.
So Salma, part of what I'm going to say to that is that this idea, it's not that it's easy, but are there ways for us to teach advocacy and action, and to give voice, and how to help people have a voice? And I'm not sure we're doing that. I'm sure that in some ways we stifle voice by how we teach. Paul?
Well, it's funny, Joan, that you should ask that question. I can't believe Salman didn't tell you that we have had a 20-year-long discussion that is sometimes an argument about this very topic. And I'll tell you how it goes. It'll be, I'm saying we really need to focus on structural racism. And Salman will say, yeah, but he's a racist. And I'm like, you don't know, you can't do a brain biopsy. And it goes on and on and on, year after year. And sometimes it gets heated. The question that you asked, though, Joan, was, should we be calling out, people and the mistakes that individuals have made? And I struggle with that. I'm just not going to shock you, right? I mean, I feel like the books that I've written are really all about the same topic. And that, advancing the notion of structural violence and structural racism, it could be a cop-out. I think it rarely is, but it's a cop-out if you can't integrate the actions of individuals into the larger structural force. And that's why I wrote in the book about Ebola, that's why I went back to the Jim Crow South. That's why I wanted to make sure that an American audience didn't otherize, the colonial practice, that they were like, well, that's the British, or that's the French, or that's the Germans. And I'll tell you, though, I did struggle writing this book, because I was looking for, I'm not a historian, but I work with, the same medical historians you know very well, Joan, and and I would try to go for archives, and I could see, from letters and memoirs and journals of colonial medical officials, I could see, again, ample reason to call out individual racist and violent persons. But, and I did, but I also wanted to do what you just did, Joan, by saying, what did we do? What are we doing now? And what will we do? And, Jim Kim, as many times, and I'm sure he's done it in front of you as well, said to, especially in talking about the movie Bending the Arc, he would say to students, including our undergraduate students and our medical students, is think about the things that we're doing right now that a future generation of young progressive people is going to look back and say, this is what you did, explain to us, mom and dad, or whatever, explain to us, teachers, why you did this thing that was so wrong. And so, I'm not, exceeding that Salman's right. I'm just saying it's just been, knowing that we are dealing with structural forces and wanting to make sure that we can't brush those under the rug is one of the reasons that I, focused on institutions a lot, like colonial rule, like neoliberalism, like, the control over care paradigm that runs through the whole story.
Paul, but even as you say that, I would love to be in the middle of one of your discussions, because I'd be sitting right in the middle. But even as we talk about institutions, we talk about individuals as actors in those institutions.
I love you, Joan. That's perfectly put.
I said that too. I could say, I love you, Joan. That's what I always say, Salma.
Oh, I'd like to, as we're coming close to our time where we're going to have to end. I want you to think about from what we take from this and what we learn from this as we think about where we are, particularly today in the world and in this country with COVID-19. And what are the lessons that are here that we could bring forward? What are the lessons that we could bring forward as we talk about vaccines that may be right around the corner that communities have suspicions about, where there are issues of trust, where there these issues of care and control have been longstanding. Yeah. And some of your thoughts about what we could do as clinicians, what we could do as organizations to help us do this better. Not just learn from the past, but what can we do now that might make us better, do a better job?
Well, when people call you on the phone, Joan, and say, hey, tell us how to explain to the community, whatever the community means, why they need to do this for their own good, that's not going to be reparative. It's not going to even work. And one of the difficulties of working in responding to an epidemic or a pandemic, you know, and I'm hoping we're going to hear from everybody. One of the difficulties is that in the heat of the moment, you just don't have a lot of time. So the pace of loss in clinical time, of course, is very rapid in the middle of an Ebola outbreak or a cholera outbreak or a COVID outbreak. But at the same time, we have to do this long-term reparative work that Michelle mentioned, right? And you know, one of the experiences we had in both Liberia and Sierra Leone was, in spite of all of the mistrust and violence. I mean, you know, and there were at one point there were an average of 10 attacks per month on the Ghanaian Red Cross burial teams, and some of them were some of this violence was lethal. We never once had anyone attack us in all those months and years. And part of it was because we were very visibly taking care of people. And, you know, I'm only bringing that up not to say, isn't it great we took care of people with Ebola? Not at all. I'm bringing it up to say humble service to other people in the face of mistrust is one of the only ways to lessen that distrust. And, you know, which I know is what inspired your question about, you know, what obligations do we have as physicians, because this group happens to be physicians, what obligations do we have to do that reparative work? And I think, you know, shutting up and serving humbly and you know, not mocking people for their vaccine hesitancy, certainly, and also just fighting the tempting notion that it is this otherness. Again, it's someone's culture or race, as if race were a genetically constructed and not a socially constructed thing, that is, you know, putting them at such great risk for COVID. It's just, there's no evidence for that. There are social mechanisms, you know, and that are related to this profoundly biological, and this is what Pardee said. She said, you know, viruses reveal these rifts. So as we're addressing the rifts clinically, programmatically, in terms of policy, we have to shut up and be humble and say, look, we're sorry about some of the mistakes we've made in the past, and we'll work for your trust, you know, as a profession, as a care delivery system.
Thank you, Paul, and maybe even be there after the immediacy of the problem so that people don't think you come and then go.
Yeah, exactly.
Others, in terms of lessons that we have learned or could learn that we could apply now.
Go ahead. I'll be super brief and just want to thank you for the question. I think that's the question that's on my mind. And I want to, number one, say it's just so interesting to me that today is the day that the DRC declared the end of their Ebola epidemic. And we happen to be having this conversation on that day, which tells me, you know, again, we can get this right. We can get it right for the next Ebola and the next COVID. And I'm not saying DRC was the model. I'm just saying that we will get through it. And I think a big part of the question we need to be asking to follow up on Paul's point again is, why did we lose the trust? And simple acknowledgement is a very important starting point, but colleagues and I did an analysis looking, and Paul and Salman are supportive of this, looking at how reparations to end the racial wealth gap would have changed COVID transmission, right? And it would have reduced it by 30 to 60% in Louisiana, which is, you know, pretty close to what the FDA set for the lowest bar for the vaccine efficacy. And I think if folks aren't interested in the vaccine immediately, there are, as important as the vaccine is, there are many communities for whom the vaccine is the least of their worries. And we should be thinking a lot about how we can make that not the case and address the material conditions that make that not the priority.
Can I just pick up on what Michelle said? This is, you know, we've had this myth that we've been locking down places. But when you look at the real data, somewhere between 35 and 42% of the workforce, many people of color, many women and others, have been working the entire time. The people who deliver food, run our buses, run our restaurants, run our stores, etc. And we've not been able to provide those people, for various political reasons, with proper protection, ranging from PPE to good ventilation to upper room UV germicidal lighting, or whatever you want to put in that we know works. And so, you know, when you start to look at it, it's been a white collar lockdown, and there's been a lot of people that have been working who are made more vulnerable. And you look at people who have become unemployed and then re-employed in the gig economy without benefits. So I agree with Michelle. I think we have to start to dig in and say, you know, there's a deep history, and then there's a very recent history of people where people have been made more vulnerable. We have a student, Arushi Shah, one of the undergraduates, who's examining how the language of referring to people as frontline workers as if they're going to get killed and then not doing anything to give them things to protect them. It's, you know, this is what's happening out there. And so I think, Joan, we're learning a lot about how we've organized our society. We knew a lot of it before, but this is just exposing it.
Pardis?
Yeah, I mean, I think that this is all beautifully said, and I know what I can add to it. I mean, but I would say that within the picking up on something Paul said, you know, about this kind of that we need to treat every individual, not treat every person who's an anti-vaxxer, someone who's crazy, but to understand there are legitimate reasons why they have questions about it, and there's things we need to do to build that trust, and ultimately seeing each person and talking to them and not putting them in a box and not seeing them as globally. There are, I'm somewhere in the middle. There probably are some people who are just, gosh, I'm like trying to get to the core of the good and I can't figure it out. I'm like, is it there or not? But I think ultimately everybody is somebody who, you know, is a person who has hopes and dreams and who, you know, has things going for them. And I think within that context, I would just say that, you know, I'd say there's certain key things that are very unique about outbreaks, but one particular one is this idea of every person mattering, right? When you think about voting and you try to convince people to vote in Massachusetts, it's hard to explain to them that their vote matters, particularly with the Electoral College, right? It's just one in a lot. And it may not even count in the way, you know, where, depending on where you're at. Or if you tell one person for climate change, if you recycle, the world will be better, a little bit, but really how much? But when it comes to pandemics, because of infectious disease and the exponential spread of an infectious disease, it is fundamentally true that one person can launch a pandemic and therefore one person can stop it. And I think that that's the framing by which for one moment we should take a look and say, hey, every person in this system matters. And we see that again and again. You feel this sense of complacency because you're like, it's not my problem. Well, in a moment it can be. And it's like, oh, but this is a disease of the old. Well, one day, you know, one mutation and it's a disease of the young. Anything can change within these contexts, and your health is completely dependent on the health of your neighbors, and the neighbors you don't even sometimes think about. And so it is important, and it is one kind of unique place to say we are literally all in this together, and we can try to lock ourselves up, and some people do, but it really will come back. And so it is a war that we only work on collectively. And so all of that's to say that I hope that around that we can think about other injustices. If it takes, I'm still fearful of my own life to get people to think about other people, I'll take it for now, and we'll work on the rest of it when it comes. But I do truly believe that is the key, to see each individual as a partner who matters.
Thank you. You know, it's we come to a close. I want to say thank you, Paul. Thank you for gifting us with your insight and your vision, your deep love of people, your sense that everyone matters, that everyone is important, your understanding of the ways in which our history and our politics and the policies and the decisions we make impact the lives that we see around us and the options that we see around us, and bringing it all together in a way that tells us, particularly those in medicine, that there is much work to be done, but we're up to it. And for giving us hope for the difference that we can make. And I thank you for that, because you always bring us back to the person, to the individual, to it be the doctor or the patient. But that's in the end what's most important. So I thank you. Thank you for your heart and your wisdom. I thank you to all the panelists today, to those who stayed with us through this webinar. Thank you. Be safe. Keep the faith.
Thank you, Joan. Thank you, Joan.